Hi, my name is Jill Decker, and I'm going to be discussing how you can apply the health belief model to public health. First, I'm going to start with a brief overview of the history of the health belief model. It is considered to be one of the first behavioral health theories to be applied to public health. The theory was created in the 1950s by Eugene Rosenstock and several of his colleagues. All of these individuals worked for the U.S. Public Health Services. And the theory was initially created to help public health officials understand why individuals within the population were not partaking in pre-screening programs related to tuberculosis. Next, I will define the health belief model. According to Crosby, DeClement, and Salazar, the health belief model can be defined as behavioral change will occur only when sufficient benefits remain after subtracting the costs incurred by performing the behavior. Thus, individuals choose an action by doing a cost-benefit analysis. Now that we have a basic definition for the theory, let's look more specifically at the parts of the theory itself. The theory can be broken down into two constructs. So within the first construct is the perceived threats. And these perceived threats can be broken down into perceived severity, perceived susceptibility, modifying factors, and cues to action. Next, you have the expected net gain. And usually these are based on demographics related to the individual. Next, I have created an infographic to help demonstrate the various parts of the health belief model. And with this infographic, I'm going to be discussing influenza vaccinations. So first, the health belief model, like I said before, has several constructs to it. And there are 4 variables that affect an individual's perception. And they include severity, susceptibility, benefits, and threat. And when we apply these constructs to influenza, what the individual is being influenced by is first, in relation to the severity, the individual is wondering how bad is the disease, and if they get the virus, how much of an impact will it have on their family? Next, when you look at susceptibility, the individual is looking at, well, do I work around a lot of people? Do I stay at home more? How likely am I to get influenza during the flu season? Third, they're going to look at the benefits, and they're going to say, how does getting the influenza vaccination help me? You know, am I necessarily is it going to prevent influenza altogether? Is it going to maybe not work? And is it beneficial to get it in the long run? And fourth, the individual is going to be looking at the threats related to the influenza vaccination. And this includes barriers that exist that prevent the individual from wanting to get the influenza vaccination, which might include the pain associated with the shot itself, the time that it takes that an individual needs to take in order to go and get the influenza vaccination. They're also going to look at how many risks are currently associated with the influenza vaccination, and if they have any concerns about a reaction related to a vaccination. Now, next, we're going to move down from perception. These all make up the person's perception, which then influence their decision. However, before they make a decision, both of an individual's self-efficacy, or how much training or education they have on the topic, as well as cues to action, which are going to include providers' guidance and things like that, are both going to impact what action they ultimately take. So when it comes to self-efficacy, what's going to come into play is if the person feels like they have the availability of a clinic nearby, or whether or not they can get their vaccination done at the hospital, how available that health service is to them. And next, when we look at cues to action, we would look at if the providers themselves can write a prescription or provide influenza vaccinations in the clinic. You're also going to look at whether or not nurses and primary care providers are suggesting that individuals get the influenza vaccination. And if family members do get influenza, that effect on the family. And also if there's any sort of like media guidance in relation to individuals getting the vaccination, flu vaccination. So all of these variables come into play when it comes to an individual ultimately making the decision to become vaccinated. Next, how do we apply this theory to public health programs? First, it's important to understand that if an individual has a low perception of threat, then they're more likely to take an action. However, if the individual has a high level of threat associated with an action, then they're less likely to actually take that action. When we're creating health promotion programs, it's important to create programs that create a realistic perception change, and this can be through either education or images. And it's also important that we increase the positive net gain perception of an individual. And this can be through either increasing the benefit value and or decreasing the barriers that are currently present in relation to that action. Currently, there are several research articles out there that use the health belief model. However, for the sake of this presentation, I found two specific articles that have used the health belief model in relation to influenza vaccination. The first article that I found was titled "Using the Health Belief Model to Understand Caregiver Factors Influencing Childhood Influenza Vaccination." And what they did was they looked at 33 villages in Pingtung County in Taiwan. The study was done in a cross-sectional design. There ended up being 2,778 participants in the study. And what they did was they created a questionnaire where they asked for the caregiver's demographics, and they also asked for the influenza vaccination history related to both the caregiver and the child. Next, I'll discuss the results from the study. So the data was analyzed using a multiple logistic regression analysis. And what the study found was that there were several predictors of vaccination, and these included age, current employment, caregiver residence, caregivers with chronic diseases, hospitalization, as well as influences in children. The study found that there was no association with perceived severity and influenza vaccination, which is not common. Other studies have found that there is an association with perceived severity, but for whatever reason, this study did not find that. They also found that the caregivers who believed that vaccinations were safe tended to vaccinate their children and felt safe vaccinating their children. And they also found that mass media had a negative effect on vaccination rates. And they believed that individuals were affected specifically by negative news related to vaccinations, and that news of adverse effects associated with vaccinations. As a result of their findings, the study recommended that public health officials work on clarifying what vaccinations contained. They also suggested that public health officials provide data on the side effects associated with vaccinations. And finally, the research also suggested that public health officials provide coping strategies to deal with negative news on influenza vaccinations. Next, I'll discuss my second study. The second case study that I found looks specifically at influenza vaccination rates in elderly population. The title of the research article was "Influenza Vaccination Uptake and Associated Factors Among Elderly Populations in Hong Kong, the Application of the Health Belief Model." So like I said before, it focuses on the Hong Kong population. It's a cross-sectional design. There ended up being 1,101 respondents. And what they did was they did a telephone survey. So here are the results from that study. First, the method that they used was a multivariate analysis. And the results found that there were several predictors of vaccinations, which included the female gender, having chronic diseases, knowledge needed to receive annual influenza vaccination, healthcare professional recommended vaccinations, and that the individual themselves were willing to pay whatever it cost in order to be vaccinated. They found that individuals were less likely to get vaccinated if they perceived that there were side effects associated with the influenza vaccination, and or if the individual was uncertain of the predictors associated with vaccinations. The article suggested or recommended that healthcare professionals be more cognizant and aware of the fact that they are the ones that should be motivating and encouraging vaccinations in the elderly population. They also suggested that within Hong Kong, they needed to improve accessibility to vaccinations, which means that there was a limited number of actual clinics that allowed or provided vaccinations. So they were suggesting that more clinics should be established throughout several communities that at this time do not have them. And then finally, they also suggested that a campaign be created to help promote vaccinations in order to increase the individual's self-efficacy. So there's always pros and cons to every theory in relation to psychology. This specific theory or model, as they call it, has several pros, but more cons, unfortunately. The pros that have been established is that it's very easy to use. It's very generalized, and any individual, whether you have a psychology background or not, can use it and apply it to communities and to cities in order to identify where associations exist. It also allows for focused research, which helps to identify specific modifiable behaviors within a population. However, there are numerous cons associated with the health belief model, and these include first, that the theory itself does not account for individual perceptions and ideas and determinants. So you have no idea of what the individual's belief and attitude is in relation to why they took the action or didn't take an action in relation to public health policy. Next, it does not take into account the habitual activities of an individual. There's a lot of factors that go into habitual activities, and it doesn't take those things into account. It also doesn't account for behavior that is social in nature, like individuals being influenced by their neighbors or the people that they hang out with and things like that. And finally, it doesn't take into account the environment or the economic factors in relation to taking an action. Obviously, if the facilities aren't there, they can't do it, or if they can't afford it, it takes none of those things into consideration. Also, it assumes that everyone has equal access to both healthcare and knowledge. And we know that that's not true at all. I mean, some people don't have computers, and some people live on their computers, and some people don't have TVs, and other people readily watch television. So there's a lot of variability there that the study itself just doesn't take into consideration. So it's important to identify these so that we know where the shortcomings are in relation to the model, so that we can hopefully try to find ways within policies or within the application of it to try to overcome these shortcomings in relation to it. Finally, how can public health officials use the health belief model? So first, communities in general should be conducting a community health assessment as per the national accreditation requirements. However, if they do not, they can always refer to hospital CHNA information and data on their population. And what they do from that is they're going to identify the demographics and health disparities within their population, and based on that they can then apply the health belief model to their population in order to identify target interventions. And these target interventions can include educating the population, they can help to develop skills within their population, or they can ensure that doctors and nurses and healthcare providers are recommending certain precautionary methods in order to help increase the overall health of the population at hand. So I hope that you enjoyed my presentation on the health belief model, and I hope that you've learned a lot about it, and I hope that you can also see how effective it can be at analyzing a population and identifying interventions that could be applied to the population in general. Here is a list of the references that I used within my presentation today.